Good evening, my name is Andres Mauricio Alvarez Pinzon. Today I'm going to talk about trends in outcome and hospitalization costs among patients with acute ischemic stroke in primary stroke centers versus comprehensive stroke centers. Stroke is one of the most disabilitated pathologies in America, and now in the last 5 years, many new treatments are looking to prevent the recurrence, to treat the acute stroke, and to prevent any disability for the near future. Now, the main question is, what is the best center to transfer the patients? What is the difference between primary, comprehensive stroke center, and what is the most important site to transfer a patient? Depends on the sign and the symptoms. In this study, we analyzed the difference between comprehensive stroke center and primary stroke center. What is most cost-effective? And we analyzed a process focused on a cost-effective evaluation between patients in primary centers and patients who bypass the primary centers to a comprehensive stroke center. The main hypothesis is estimated the cost effectiveness of care in primary stroke center (PSC) versus comprehensive stroke center (CSC) in patients with large vascular occlusion is higher and less effective comparing patients who bypass primary stroke center and are admitted to the comprehensive stroke center. In easy words, it looks like people who bypass primary center and need a complex intervention is easy to be recovered when they go directly to comprehensive stroke center, and the cost effective is better. This is a retrospective comparative study. We got IRB approved by FAU IRB. We completed a literature review between 2010 to 2017 to find the main power and to find the difference, allow us to make a recommendations to treat and bypass primary to a comprehensive stroke center. We review the main treatment, the follow-up visit at 7 days, 30 days, 90 days, and 1 year. One of the main points is the hospital stay and mortality. The evaluation of the hospital stay was really important since each day of hospitalization in ICU is around $5,000 and the length of stay is totally different of the recovery process, but at the same time, less length of stay is equal to better recovery. Talking about hospitalization costs, we reviewed the costs and complications secondary to primary center to comprehensive center. We reviewed the mean cost of hospitalization, including the intervention, CT scans, MRIs. We reviewed using a BOC plus analysis, a statistical analysis between the difference of both sides. We reviewed the hospitalization costs in total and the quartile analysis. We reviewed the patient factors, population, treatment, cost effectiveness, and actually the mean hospitalization cost. The main result shows no statistically significant differences between groups, so we compare apples by apples. But let's see this. The total cost when patients go to a primary center and then is transferred to a comprehensive stroke center is $248K plus minus $48,000. Different if the patient is goes straight to comprehensive stroke center, that is near to $168K. The mean lasting normal is the same in both groups, or was the same in both groups, and actually the mean length of stay is higher when the patient go to the primary center and is transferred to a comprehensive stroke center. We parallelize and compare groups in terms of stroke scale, recovery outcomes, 24 hours follow-up, 3 months follow-up, and 1 year follow-up. We review as an initiative of best recovery when the patient recovers the functionality 50% or more after 24 hours. And the endpoint was the cost of total hospitalization and actually the rehab center. We found 323 people with diagnosis of ischemic stroke in a 50-month period. there were no significant difference between groups. We found that 132 people received initial attention at primary stroke center. What the result shows? We found a median time from onset to large basal occlusion recanalization shorter in patients with direct access to a comprehensive stroke center. That means 62 minutes versus 138 minutes. So there is a 1 hour delay between one center to another, and there were a statistically significant difference of 0.0012. And the NIH, that is the stroke scale, or the outcomes, was better in people who bypass primary center. The p-value was 0.0021. The plot analysis reviewing TPA, endovascular rescue, and thrombectomy shows a hospitalization cost less or equal in people who was treated in comprehensive stroke center versus primary center, and the length of the stay was 30% lower in people who bypass primary center. And this is my main point, and actually the most important. Compared to initial attention at primary center to a straight admission to the stroke center, was linked associated with an odds ratio of 2.33, or a significant difference for excellent outcome after adjustment for the stroke scale and the recovery process. What that means? That outcomes are better when the patient is treated in comprehensive stroke center. Why? The reason is this. When people go to the primary center and the lancing normal was more of 3 hours, they cannot do any treatments because they cannot provide TPA, that is the medication. But if the patient bypass the primary center to a comprehensive center and the lasting normal is more of 3 hours, they have the ability to do an endovascular rescue, that is using a device they put inside of the blood vessel and take out the blood clot. That is the main reason. So the main question right now is, what is the choice of the site? Other department policies to offer a most minimum effective procedure to patients with acute ischemic stroke. But comprehensive stroke centers should be offered as a first option for patients who already passed the 3-hour window for the TPA treatment. Primary stroke centers usually offer as a primary offer for patients who are in the 3-hour window or are near to the primary center. So most of the time, who is going to do the decision is the rescue. That's why it's really important to train all population in our pre-hospital admission team to decide where they need to transfer the patient. Limitations. This is a retrospective and not prospective randomized control study that allow me to review and make some recommendations. But actually, to feel comfortable in science, we need to do prospective randomized control study to make a final recommendation. This is just the start for a comprehensive evaluation of our stroke centers and see what is better for the patients. What is the conclusion? And reason for one single center to decide in the acute management to address this difficult pathology, a center that will be affecting the acute and mid-term run, minimally invasive, and cost-effective at the same times? I want to tell you, depends in each case. Each case is different. We believe that the comprehensive stroke center and the satisfying result in experiencing team propose acute large vascular occlusion treatment by endovascular rescue as a first option for the management of acute ischemic stroke. It depends of the time frame window. So who made the decision is the pre-hospital team. They need to know if they need to bypass or not. So our recommendation is to treat and train our pre-hospital teams. Thank you very much for your attention. Thanks very much to be here. If you'd like to learn more about these topics, you can find here the reference used in this manuscript. Thank you. Have a good day.